and welcome to Healthy Living. We're here today with Kelly Presnell, Director of Marketing at Hilton Head Hospital, who's going to share with us who we're going to be talking to today.
Yes, today we have Dr. Rick Hussong. He's one of our general surgeons on the medical staff. He is partnered also with Dr. Robert Soares and Dr. Tom Rizicki. They make up our general surgery team here at Hilton Head Hospital. And Dr. Hussong is going to talk about general surgery just as a whole, and then he's going to focus in on a couple of other topics that are of interest to the general public.
And I understand that he is Chief of Staff. We're going to touch a little bit on that also. So stay with us. We'll be right back with Dr. Rick Hussong.
Excuse me.
Hi, can I get through, please?
Dr. Newman.
You know, there has to be a better way. A way to skip the ER waiting room. Like this lady over here. All she did was log on to inquicker.com to hold her son's place in line. Now they can wait at home and skip the ER waiting room. Now, which would you choose? This or this? Hold your place online at inquicker.com and skip the ER waiting room. Ooh, is that hot cocoa? Oh, help yourself.
We went to the emergency room, and thank heavens we did.
They discovered that I had 2 totally blocked arteries, and I ended up having double bypass open heart surgery. Well, I stayed in the hospital for just a few nights.
To the staff at Hilton Head Hospital, I would express the deepest gratitude that I possess. They literally, quite literally, saved my wife's life.
Hi, and welcome to Healthy Living. We are here today with Dr. Rick Hussong, and we're very excited to have you and talk with you. Lots of things to talk about today that I think many of us are interested in. Part of the goal of having you today is to demystify some of the things that you do and really define for us what general surgery today looks like, and then for your practice specifically, what are some of the things that you do? And then finally, to talk a little bit about diverticula, diverticulosis, diverticulitis, and what you have to do with that.
Okay, great. Thanks, Debbie, for having me again. As always, general surgeon, we do a little bit of everything in surgery. It's coned down more in modern times or more recent, particularly the last decade. But a general surgeon, for the most part, does things like hernias, gallbladder surgery, colon surgery that we'll talk about, lumps and bumps, breast surgery, thyroid, and we also do a decent amount related to like skin cancers or even melanomas and lymph node biopsies.
If we could kind of go back through the ones that you said, for example, let's start with a gallbladder. At what point in time would I come to a general surgeon? Am I symptomatic for that?
Correct. A lot of people have gallstones and no symptoms, and there are no symptoms related to gallstones. There's no indication for surgery.
Okay.
The indications for surgery is when a patient starts having symptoms, and typically we meet those people in referral from their primary care physician, or some people
in
their
the
worst
ER.
attack, the emergency room. So that's how we usually get most of our patients.
And that's okay. So that's the gallbladder. Then when we're talking about lumps and bumps and things like that and hernias, again, would I be symptomatic for those things? In other words, I guess what I'm really trying to get at is you're not a primary care physician.
No, and you wouldn't want me as one.
So I'm going to be referred to you at that point in time.
Correct, and a lot of people do come to us self-referred, particularly hernias many times, or lumps or bumps. People discover most hernias are not symptomatic. People will discover that they've got a bulge or a lump that they may feel or see.
Painful?
Most of the time, no. Groin hernias, many times people will tell me that it's kind of a heavy sensation. They know it's there, but it's not a problem for them. So
once you diagnose something and you have that diagnosis made, at what point in time then do you begin the surgeries? Are surgeries usually pretty, I don't want to say urgent or emergent, or are they something that we can actually plan?
A lot of our surgeries are planned and elective, but we certainly have a fair number that are on the more urgent or even obviously the emergency course. You know, emergency surgeries for the most part are going to show up in the emergency room, but most of our gallbladders, hernias are going to be elective cases.
When you see someone, Dr. Hussong, do you follow them throughout the surgery, post-surgery? What does all that look like in today's world in the hospital?
It's interesting you ask that. One thing about surgeries, we don't have those long-term relationships with a lot of our patients, and it's actually gotten a little worse with laparoscopy. You know, it used to be you came in, had your gallbladder out, you might be in the hospital, you know, 5 days.
Right.
Now you'll come see me in the office for maybe 30 minutes. I'll meet you the day of
Wow.
surgery for about 5. I may meet you after surgery, but you won't remember it. And
That's
we'll
true,
see you for
isn't
about
it?
2 post-op visits in the office because it's all outpatient. So it is a lot different than it used to be, and but we do follow people through their convalescence. For me personally, that's usually for most surgeries a visit about 1 week after the surgery, outpatient, and then about a month after that.
Looking for what? I've always wondered that at those times.
Main thing we're wanting to check is make sure that people are doing as we would expect them to. Most infections.
Does that translate as being compliant? A little bit.
we hope for compliance. Okay. We don't always get it, but certainly compliance is helpful. Main thing we're looking for is make sure that people are progressing like we expect them to. And many times, actually, people don't quite know what to expect, and a lot of it is just reassuring them that they are doing appropriately. And we try to prepare them ahead of time. But as I tell my patients, everyone is different.
And I think what you said is probably the most important thing that I've ever heard a doctor say, and I think we all have, our imaginations run wild oftentimes. And I think because we're not the physician, we don't know what to expect. And one of the things that I have heard about you that's really impressive is that your patients say that you are very thorough in sharing kind of what to expect post-surgery and really what's going on.
I mean, I think that's important as a surgeon and a physician. Is just, I mean, we have a process called informed consent for surgery, and to me that means tell people what to expect afterwards. I think patients do a lot better, are a lot more pleased with the overall process if they kind of know what to expect. And
are most of your patients in today's world pretty well informed? Do they do a lot of reading? Do they do a lot of investigating?
Very. I mean, between people talking about health more and the internet, there aren't many things that people can't find out on their own.
Right, they could pretty much perform their own gallbladder surgery
I
if
think
left
so
alone.
sometimes. But one thing that it doesn't seem like we hear about as much as you already pointed out, is the convalescence period and kind of what to expect. Or if they do know about that, they're hearing the horror stories that show up on the internet or the bad time someone else had. So again, I think it's important to tell people ahead of time what the majority of people are going to experience. And I've even had to tell people some of the bizarre, really unusual complications just because when they happen and they're not prepared for it, it's a big shock.
Do you have to assess a patient when you're talking to them? And this probably is more the art of medicine, and sort of assess if you're going to tell them some of the side effects and they're going to just somatically have them, they're...
No, I mean, as you know, our responsibility again is to do informed consent, let them know
to be
what
clear.
to expect, what the common complications are, and maybe the uncommon but serious complications. I think what you have to do more is gauge your patient and figure out the best way to approach that conversation with them. I joke with my patients, sometimes I'm surprised they even let us operate after we get done doing the informed consent process, but you have to remind them again, most things we're talking about are not common, and most things we're talking about are actually very treatable as well.
We've been talking really a broad spectrum for the past couple of minutes. I'd like to drill down a little bit and talk specifically about colon health, and I've been hearing more and more about diverticulitis. Like to kind of know anatomically what we're talking about and just the process.
Sure. I mean, diverticuli are very common, and actually I was doing a little reading recently, and it wasn't very common until the 20th century, and Western diet with the refined sugar and the white flour decrease the fiber in our diet, and diverticulitis started to become a process.
What is it?
Diverticuli, and there's a big difference
Okay.
there. Diverticuli or diverticulosis just refers to the presence of the diverticuli, and they're like little weak spots on your colon. I don't have a great analogy, but if you've ever seen a weak spot on an inner tube where it kind of pokes out separate
Yes.
from the inner tube, that's kind of what a diverticulum is. Most Americans start getting them in their 30s. I think the figure is something like 60% of Americans will have them by age 60.
Because we have a lousy diet and we're not getting the fiber to keep us strong?
Correct. And most people will not have symptoms from them.
Okay.
Now, when they start having symptoms, the most common thing we see is diverticulitis.
Okay.
And that refers to inflammation. We're not exactly sure why, but we think the narrow pocket on the opening gets inflamed and creates an infection in that area, usually presenting as some pain on the left side because that's where most diverticuli are.
Oh, now why
The
is
left lower
that?
quadrant.
Okay, all right.
That's where the stool starts liquid on the right.
Right.
Becomes more solid as it goes around. There are pressure gradients that change in the colon, but most diverticuli are on the left side, and that's where they're
Interesting.
mostly problematic. So it's left lower quadrant, abdominal pain, sometimes fever, usually no bowel changes. Now, the other condition we have with diverticuli is diverticulosis, which is just presence, but sometimes they bleed, and that's a diverticular bleed.
Because it breaks through, or because it's...
Diverticuli occur where there's a blood vessel that pokes through the wall of the colon.
Okay.
So that is a natural area for weakness to develop.
At
And
what point is a surgical intervention necessary?
most surgery for diverticuli are related or around diverticulitis, again,
Okay.
the inflammation,
The inflammation
or
part.
infection. Rarely do we operate for diverticular bleeding. That's more of a gastroenterologist problem.
We're going to take a quick break. We're going to come back and talk a bit more about colons, colon health, and some of the things that can go wrong. So stay with us. We're here with Dr. Rick Hussong, and we'll be right back on Healthy Living.
Excuse me. Hi, can I get through, please?
Dr. Newman.
You know, there has to be a better way. A way to skip the ER waiting room. Like this lady over here. All she did was log on to inquicker.com to hold her son's place in line. Now they can wait at home and skip the ER waiting room. Now, which would you choose? This
Dr. Joyner.
or this? Hold your place online at inquicker.com and skip the ER waiting room. Ooh, is that hot cocoa? Oh, help yourself.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library. Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients.
Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here to Hilton Head Hospital.
We are back here on Healthy Living. We're talking today to Dr. Rick Hussong, and we're talking about really being a general surgeon, some of the things that are involved, some of the procedures that you do. We've kind of graduated now to specifics, and we've been talking about colon health and diverticulitis and diverticulosis. And during the break, you were talking about, it was funny, we were all saying peanuts. What about peanuts? You said old wives' tale.
Yeah, there was actually, I mean, I always said all along I didn't believe it. I've never operated on someone for diverticulitis and found nuts. In the diverticulitis.
That'd be interesting.
And it's hard to believe a little strawberry or sesame seed is going to cause an attack.
True.
And there were actually, I think it was about 3 or 4 years ago, there was a study that came out, and those people that ate nuts actually had a little slight decreased incidence of diverticulitis than those who did.
It's good fiber, right?
So I tell my patients, eat nuts if you want. A lot of them say, I don't care, I don't ever want an attack, so I'm just going to stay away from them anyway.
If you have one attack, are you prone to recurrence?
We do know that if you do have one attack, there's about a 30% chance you'll have another attack. We used to recommend surgery for one attack in very young patients or 2 attacks.
Okay.
We now know that most severe attacks actually occur the first time. And severe attacks are perforations or a hole in the colon that leaks, or an abscess. And I didn't even honestly know this till doing some recent investigation, that most severe attacks are the first one.
Very
so
interesting.
we used to tell people, get surgery so you don't perforate on subsequent attacks. We now know that that may not be true.
If your colon is not healthy and is subject to these diverticula, do you have a diverticula, or will there be multiple, or do we know when you go in to do surgery, are you looking for?
Well, it only takes one.
Okay.
But most of us have more than one.
Okay.
And they're, again, usually concentrated on that left lower side. When we operate, we're doing it for symptoms or a complication, and it's usually well-defined in a small area, and that's what you need to address. It would be impractical to take out every diverticulum in the colon, because for some people that could be the entire colon.
True. All right, prevention, you said high-fiber foods. Talk to us about that. And then if I am symptomatic and have an attack, can I reverse all of that?
Well, prevention is really high-fiber diet, brands, fruits, vegetables, natural grains, and a well-hydrated diet.
And well-hydrated. Okay, that's probably important too.
Correct. Now,
why? Because the processed food is just not...
You're getting out of my area there. I don't know. It has something to do with the liquid content of the stool and transit time through the colon.
Okay.
And the pressure that occurs with that.
You did know.
Well, kind of. As far as when you have an attack, usually when people have one, we start antibiotics as soon as possible. Most people with a mild attack are going to experience great improvement in their symptoms in about 24, 48 hours.
So the goal there is to rid yourself of the infection.
Correct.
Okay.
Correct. Now, there is evidence that if you do fiber, that you will lessen your chance of recurrent attacks.
Okay. So so that's exactly what we're asking.
Now, you're not going to cure yourself of diverticuli. Once you have them, they're there. They're not going to disappear, but we do know that there's less chance of further attacks.
Do you come in then for regular checkups to see, or you just wait again for the symptoms to reoccur?
Wait for it to
reoccur.
Yeah.
Sounds like a lot of fun. All right, we have. Go ahead.
Go ahead.
Well, I was going to say, kind of shifting from the colon to the hospital, if you will, and what you're actually doing here. I understand you are the new chief of staff.
Yes, I am.
Congratulations. That's
thank you.
Quite an honor.
I have somehow managed to become chief of surgery for 2 terms, vice chief, and now chief of staff.
How long have you actually been on staff here?
I've been here since January 2003.
Oh my gosh, where does time go? And as chief of staff, what are you really doing? Are you representing then the physician staff?
Correct, the medical staff, the physicians, and what we do mainly is look at our bylaws, the rules and regulations that we have to operate by within the facility. We're involved also in quality control issues. I mean, the hospital obviously has their own arm of quality and procedural, but we work in conjunction with the hospital.
What are some of the interesting things that as chief of staff you've gotten to kind of wrap your arms around that perhaps as just a physician maybe you weren't, not that you weren't privy to, but that really you weren't involved in day-to-day quality control being, I would think, quality?
Well, first of all, I'm only starting my 3rd month today, so I've only been doing this 2 months. But the process that I became chief of staff, again, was chief of surgery, then vice chief of staff, and most of our chief of staffs come up through the ranks like that. And so I don't feel like there's a whole lot I'm doing as chief of staff so far that's different than what I've done before. You get, and actually I think in a lot of ways the department chiefs, chief of surgery and chief of medicine, actually have a lot more responsibility in a lot of ways than I do. We're very
basically,
involved.
yeah, you basically take the collated material and sort of present it. You are the united voice. Is that really what?
I'm kind of the leader of the medical staff. We have a medical executive committee, which is our department heads and some other members that work on this and then report to the board. And I'm kind of go-between between the medical executive committee, the medical staff, and the board. But again, as chief of surgery and then the same for the chief of medicine, we're very involved in quality with what we call a peer review process. Also, we have ongoing focused professional practice evaluation where we make sure people are following within appropriate guidelines, doing appropriate evidence-based medicine.
It's been really interesting in talking to nurses, in talking to some of the physicians here, and actually patients who have had surgery here. And I hear so many positive things about, of course, the physicians, because I'm biased because I know a lot of you and you're incredible, but about the professionalism of the operating rooms. They're state of the art. They're really incredible. Has that been your experience?
Oh yeah, I mean, I have no qualms with the facility here, and I wouldn't work here if I did. And you know, that's one thing my wife and I looked at when we moved down here. Is this a place we would want our own care? And the answer is yes. You know, I've worked at a lot of different places, and between residency, medical school, and then being in Toledo before coming here, I've seen a lot of different hospitals, and this is by far right up at the top.
We've had the opportunity to go visit the operating rooms before, and they really are pretty impressive.
Yeah. And I think one thing that we have going for us here, we're a small place, so we can't always do everything, but I think we can provide a lot more intimate, personalized care. I mean, I had a patient who had to go elsewhere one time for some care that just wasn't available here, and she was so glad to get back here where she said,
where she
I'm
felt
not
like
a
a person.
I'm not a number.
It's funny that a patient that you just had recently said that to me. They felt like they had such good professional care, and she felt like she was a real person, and that's a real testimony. How do you work? Are you on call if someone comes into the emergency department? Is that how the surgeons?
Yeah, I mean, we have rotations. Physicians cover their own practices, but then they're also responsible for covering the emergency room or the hospital in general. Way it works in my group, Dr. Rizicki and Dr. Soares and I all rotate calls. So roughly we're on every third day or every third weekend covering for our practice and the hospital for any what we call unassigned patients that show up who have not seen us before.
Are most of the surgeries that you all do now in today's world outpatient surgeries? Are they inpatient? And if they're inpatient, what is the average? And I know this is a terrible question. What are the average lengths of stay?
A lot of our surgery is really progressing to outpatient. Colon is probably one of the surgeries we do that has the longest stay. And with the open procedure or the large incision, it was typically a 5 to 7 day hospital stay if it went uncomplicated. Now with laparoscopy, we're getting people out in about 2 days.
How do you decide whether it's a laparoscopic procedure or if it's the open procedure? Is it just?
Pretty much we'll try anything laparoscopic that we think there's a chance that it can be done. You're not burning any bridges by trying something laparoscopic. Worst case scenario, you can't do it. You could do the old-fashioned large incision.
If you were to talk to me about surgery when you first started here in 2003 versus surgery and surgical procedures today, how do you see the evolution or the revolution? Is surgery shifting?
It's shifting. I mean, we've seen some of that already, and I don't know how much further it'll go, but again, the shifting from large incisions to more and more laparoscopy and more, or a bigger shift from the inpatient to the outpatient. I think you're going to continue to see that. Obviously, there's certain limits we're going to approach that may not be surmountable, but again, a lot more of the outpatient, less invasive.
I'll tell you, it's always fun to talk with you. I feel like I get a really good insight into surgery, and now it's been very interesting to talk a little bit about Chief of Staff and what that really entails. Thank you, Dr. Rick Hussong, for visiting us. Thank you all for sharing your time with us here on Healthy Living. Have a great day.